Welcome into another episode of For Your Health, the podcast brought to you by Roane General Hospital. I am your host, Andrew Miller, and we're going to talk all things fat today. Very excited about talking about fat, just in a personal journey of me trying to lose a whole bunch of it. There's all sorts of things surrounding the topic of fat, and none better to finally be back in the hot seat than our good friend, Dr. David Francke, who is the cardiologist here, one of three at Roane General Hospital. Dr. Francke specializes in the advanced treatment of cardiovascular diseases and other heart conditions. Visceral fat is a type of fat stored deep in the abdominal cavity surrounding vital organs, such as the liver, stomach, intestines, even the arteries. It's been linked to some increased serious health concerns and some heart disease and type 2 diabetes stuff. The heart disease is why we have him in the hot seats. Patients in the Prescription for Your Health program that complete that InBody scanner we've talked about, they are provided with a little bit of a measurement when it comes to that situation. We're going to talk about this stuff, Dr. Francke. You're going to keep me in line and on path, I guess, as best we can when we're talking about something known as visceral fat. First off, thanks for being back with us again.
Hey,
it's been a while.
Yes, it has been. It's been several months. It's great to be back.
It's not like you're busy or something. Treating patients.
A little bit, but certainly we got time to talk about some important things that pertain to what we do here at the hospital and in the Health and Wellness Center, and certainly to our patients.
Now, I'm going to preface this conversation about visceral fat in that personally going through my own health rebirth, what do you want to call it? And so the Prescription for Your Health program does offer what they call an InBody scanner. And that InBody scanner is a machine that measures a whole host of things within the human body. It takes your weight. It takes your BMI. It takes all sorts of things and adds, multiplies, carries the one, whatever. One of the things that's in that is body fat percentage, and then they also have something called a visceral fat percentage marker in that InBody scanner. And so when you look at that, and people may not know, like, well, fat's fat, right? What are we talking about? When we're talking about visceral fat, the name visceral fat, what are we talking about when you describe that name?
Yes, that's a great question. And we get a lot of questions about visceral fat. People look through their InBody scan when they're in the fitness center, and that's one thing that a lot of patients aren't familiar with. And it's something that's actually kind of difficult to wrap your head around because it's not a fat that you see. Okay, so visceral fat is essentially fat that's surrounding our organs. All right, a lot of people may be surprised to hear that. They're familiar with the fat that they can pinch on their belly. What we call that subcutaneous fat, but there's actually fat that surrounds and sometimes infiltrates the organs of our body. A couple examples of these. So the heart has a layer of fat around it, okay? And also, and this is something that's a little bit more well known to patients, I find. A lot of patients have heard of something or may have something called fatty liver. So fat can infiltrate the liver and cause liver damage. And this is also a form of visceral fat.
Okay. Let me ask you about this. Well, you're going to have to go back to anthropology school and archaeology school. Why do we have fat surrounding our organs? Is there a level of fat surrounding your organs that was there to protect them? Is it something we don't need, something we do need, and then too much of it obviously is not good?
Right. So that I don't know how to answer that question from that standpoint, but I will say that when we start to put on, there's a level that's certainly not unhealthy, but as we start to accumulate excess fat and fat stores that may have been good during times of starvation back in the day. But when we start to put on excess fat stores, one of the places that we see excess fat stores, and this can become unhealthy, is visceral fat.
Yeah.
Okay. So not just the fat that we're able to see when we look at ourselves, but fat inside of our body, deep inside of our body as well.
And as you mentioned, fat surrounding the heart, we were talking off air about this. There's a name for the fat around the heart and the issues that go with that.
Right. So epicardial fat.
Okay.
Some call it pericardial fat. And there haven't been any studies that conclusively tell us that causes a problem for the heart. Okay. Now, we do know that fatty infiltration of the liver can cause liver damage and even cirrhosis or liver failure. So that is one instance where visceral fat can cause significant problems. But beyond that, there really haven't been any definitive links with good, strong medical studies to tell us that visceral fat is really, really unhealthy.
Well, I like the way you mentioned infiltration. That's never a good word. Infiltration of the liver with the visceral fat. People often may not understand. They hear visceral fat. They say, "Well, that's my belly fat." Mm-hmm. Not the same thing, correct? Not the same thing. Belly fat, as you mentioned, just if you're seeing that, that's the subcutaneous fat we're talking about. Is that correct?
Well, yes and no. So when we think about belly fat, one of the ways that we can objectively measure that is with a tape measure or with a waistline, okay? And so certainly playing a role, and what we notice the most is the fat that's underneath our skin or the subcutaneous fat, okay? A lot of people put on fat preferentially around their waistline, okay? Yeah. And so that's something that the subcutaneous fat is more evident, it's more clear, but there's also visceral fat on the inside of our abdomen that also contributes to our waistline, to those measurable those measurable things that we can keep track of, like our waistline. So yes and no. I mean, when you hear belly fat, you think of the belly fat that you can grab a hold of. But there is a little bit more at play there.
Yeah. Why is it that the belly fat is the first to show up and the last to leave when you're trying to get in shape? Why is that?
So some people put it on. Some people put it on in their belly. Some people put it on in their hips. But yeah, there's more of it there, and it can certainly hang around longer.
Yeah, man, I tell you, that's one thing that I see in social media. Let's just say social media can be so good for so many things, and it can be so bad for so many things. One thing I've enjoyed during this health journey that I've been on is, I'll take in thousands of bits of information from so-called experts or so-called influencers or whatever you want to call it. Mm-hmm. And then I'll take the 95% rule, in that if I see something repeated in thousands of bits of information 95% of the time, I generally tend to believe that it's got a little more validity to it. But I also see things like, if you want to eliminate belly fat and just belly fat, this is the way to do it. And then 95% of the people are saying, you can't do that. You lose fat as you lose fat. You can't isolate it. Is with your knowledge of this, is that something that's more true? It's just you're going to change your lifestyle and it's going to eliminate body fat as it eliminates it.
Yes, I would agree with the latter, that it's difficult to lose fat specific to one area. And that as you lose weight, you're going to proportionally lose fat all over your body, and this includes visceral fat. So I recommend just a general weight loss plan to include diet and exercise. And if you're able to stick to those, the goals that you set out with on your own or with your medical provider, you're gonna lose weight.
Sorry for the bad news, folks. There is no miracle. Consistency. That's the way it is.
Consistency.
You had mentioned the fatty liver issue. That's obviously a big problem for people. Are there any other risks linked to, or that you guys know of? As you said, there's not a whole lot of studies behind this, some of this stuff, but are there any other things that you have encountered that could be a risk problem with too much of that visceral fat around your organs?
Sure, not with visceral fat, but not specifically with visceral fat. But I will say this: there, with abdominal or truncal obesity, as we call it, with abdominal obesity, there certainly have been larger health problems that have been proven to arise from that.
Okay,
so we're talking about subcutaneous fat as well as visceral fat that increases that waistline. Yeah. Okay, when I was in medical school, there were studies that came out about something called the metabolic syndrome. Okay, and one of the markers of the metabolic syndrome was an increased waistline. Okay, a waistline of 40 for men.
Ooh.
And 35.
Sorry, I'm
for
just
women.
having flashbacks right now.
So this was one of the markers of the metabolic syndrome. The other ones included high blood pressure, high triglycerides, a low HDL cholesterol, and so in other words, poor dyslipidemia or poor cholesterol levels, high cholesterol. And what we found is that with a higher level of abdominal fat, patients are at risk for high blood pressure, high cholesterol, insulin resistance or diabetes, all of which are major contributors to cardiovascular disease. So with heart health, it's really important to lose weight.
Exactly.
So that we don't have this abdominal obesity.
Yeah, and as we said, you come at this as a heart specialist, a cardiologist, but it does link to belly fat.
Absolutely.
I mean, everything links to everything when you're trying to get in shape and be be healthy, obviously. But I think people need to know that. They need to know, well, my heart's fine, belly's totally different. No, it's linked to other things. So
absolutely,
in the end, we want you guys to get healthy, obviously.
That's right.
So we talked about the InBody scanner. Mm-hmm. Why is it important, or why might it be important to get a measurement of a percentage of visceral fat that thing does emit for you? So you get on the InBody scanner, and it reads out all this stuff. Mm-hmm. It reads out how much your arms weigh, each individual arm, how much your legs weigh, your BMI, your resting metabolic rate, your weight, your trunk weight, all sorts of stuff. It gives you more information than I could even process.
Yes, fat contents of individual arms. And it tells you everything you ever wanted to know.
There is a section on that gives you a percentage of visceral fat. So whatever you call that, the fat around your organs.
Yes.
Why is it important to see that, at least, to see that percentage for you?
Mm-hmm. To be quite honest, in my opinion, that's one of the markers of lesser importance with the InBody scan. It is more information, and it is a marker that we can keep track of through our fitness journey. One of us at this table has reduced his visceral fat substantially over the last few months. The other probably hasn't. I've only had one.
Well, the other one hasn't had to.
But
if you stay in shape, you don't have to get in shape, Dr. Francke. You know that?
but I mean, it is nice, and I'm sure you could speak to this. It is nice to look at the InBody scan and look at our results from month to month and see positive progress, no matter what marker we're looking at. Now, as far as the visceral fat, why is it important to lose visceral fat, or why is it important on the InBody scan to see these numbers go down? There really isn't a lot of good data out there on the medical side to suggest that targeting visceral fat is going to play a major role in preventing cardiovascular disease. Now, that said, we do look at other measurements, as I was mentioning earlier, like the waistline, body mass index, which is also something that we see with the InBody scan, that do have prognostic markers that tell us that, you're overweight, you're obese. This is going to, or this puts you at a higher risk for serious things like cardiovascular disease. So those are the things that I pay attention to a little bit more. And one really nice thing about the InBody scan is that, there's really no perfect test for all people. We're all different.
Yeah.
Okay. So, BMI, it's something that we frequently use, the body mass index, something that we frequently use in medicine. It's going to be elevated in obese people. It's going to be elevated in bodybuilders. Okay. And patients with a lot of muscle mass. So one thing that's really nice about the InBody scan that we have here is it allows our patients to see their skeletal mass volume as well.
Yeah.
And that kind of gives us an idea whether or not all of the weight that we're carrying around is healthy or unhealthy.
So I think about this when we're talking about the different types of fat. And as you said, the InBody scanner is so nice because it does break down so many things. And whether the visceral fat marker is as important or not, I guess my feeling is, in general, as a cardiologist and someone who has linked, obviously, belly fat itself to problems with the heart and things like that, all the fat you want to keep to a minimum. You want to keep it all, no matter how. You want to keep it all down.
Yes.
And so that is one of the reasons that maybe you see that marker of visceral fat, and let's say it is that 21%, and you drop it down to 12%. No matter what, that's a good thing to see that.
For sure.
Okay.
Yes.
I was trying to figure out, it is still that important sign to see, okay, that's a part of the fat that you have.
Yeah.
And watching that drop is a good sign. So.
Right. Yeah, absolutely. And, this ties into a lower body mass index. It ties into a lower losing visceral fat, that is. It ties into a lower body mass index. It ties into a lower waistline. It reduces our abdominal obesity, thereby reducing our risk for developing cardiovascular disease.
Is there, I might be loading this question, is there a level of visceral fat that's concerning, or is it simply just
there's not
patient to patient? You got to figure it out.
There are no markers that tell us that a visceral fat level of 20 something versus a visceral fat of 14 or 15 is more dangerous than the other.
Yeah.
Now, we have other measures that are well defined, and in fairness, this may be because it just hasn't been studied very well. Part of the issue with studying visceral fat is that while an InBody scanner is good for measuring visceral fat, the best ways to measure visceral fat are with really expensive and time-consuming imaging studies like MRI and PET scans. And with those, you have the risks of having the tests, the length of time, waste of medical resources, they're all, and cost. So there are all these barriers to really doing a great job of measuring visceral fat and studying the importance of visceral fat.
Exactly.
So, we have all sorts of other things that we look at related to fat and related to cholesterol levels that I know and can counsel my patients on as a cardiologist. Hey, this is unhealthy. We need to work on this. But visceral fat just is not one of those right now.
We should call this podcast Debunking Myths, Misconceptions,
there we go.
Untruths about visceral fat, the name visceral fat, all the fad, all the rage these days. So I'll ask you this then. And I guess maybe this is just, again, we'll take it right. It all circles back to there truly isn't a miracle cure situation, a miracle drug, a miracle this, a miracle that. When you're trying to be healthier, you're trying to lose body fat, how can patients lower their visceral fat level or their health risks? Maybe you just lump it into how can you lower your body fat percentage? How can you increase or decrease health risks?
Right. So that's what I would recommend to my patients. I would not tell my patients to specifically try
Work on visceral fat.
Work on visceral fat, because I don't know how to do it. And really, there are some people that would say that they do, but their information is not based on really good data.
Yeah.
Okay. So I would tell my patients to diet and exercise in accordance with the recommendations of the American Heart Association. And that includes aerobic exercise, at least moderate intensity aerobic exercise, with a goal of 150 minutes a week. So a lot of patients try to do about 30 minutes 5 days a week or 50 minutes 3 days a week. And then also dieting. And dieting's a little bit more complex because different patients have different needs.
Yeah.
And I think that we've kind of discussed that with our dietary experts on this podcast before. But diabetic patients are going to have different needs than patients with high blood pressure or isolated high cholesterol. Now there are certain diets that help with all of those things.
Yeah.
But calorie restriction, essentially the nuts and bolts of losing fat, we want to allow our calorie expenditure, in other words, how many calories we burn, to be more than how many calories we take in.
I think about that, and I think of the great and just immortal words of a National Wrestling Hall of Fame coach from Roane County High School and Spencer High School, and Gary Bender. You may not even know Coach Bender. I don't know if you know Coach Bender or not, but he always said, calories in versus calories out, guys. Calories in versus calories
that's
out.
That's it.
And although, as you said, different types of patients may have restrictions on certain things, if you are wanting to lose body fat, including visceral fat, you must be in a caloric deficit.
That's right.
And unless we break it down, 3,500 calories equals a pound of fat. Is that, am I close to that? 3,500 calories a pound of fat?
I'd have to look that up, to be
I
honest
can't remember. I think I saw that 7 days a week, 500 calorie deficit a day, 3,500, it's a pound of fat. We'll edit this out if it is completely incorrect. But yes, you must be in a caloric deficit so your body can start to burn that belly fat, that body fat, belly fat, visceral fat, all of it.
Right.
You have to do that. So it goes back to the simplistic point of it's not simple. It's hard to get yourself to start it, but you must be consistent with a good diet and exercise. You just have to do it.
Have to do it and have to maintain it. Now, you know, there are some patients that have also tried really, really hard and done all the right things as far as exercise is concerned, as far as diet is concerned, tracking calories, putting in time as far as exercising goes, and they're just spinning their tires. And, you know, there are other things that can be offered for those patients. This is a little bit out of my wheelhouse, a little bit out of my area of expertise, but, you know, there are weight loss surgeries that are indicated for those patients, bariatric surgeries, and now there are medications. There have always been medications, but we're having better results with the GLP-1 medications as far as weight loss is concerned.
Yeah, we had a really good couple of podcasts with Dr. Dejani.
Oh, he's an expert.
He was,
those, yes.
He got us through the GLP-1s first, and the excitement that he had with those, and then I'm not going to remember the acronym for the SL somethings.
SLG2 inhibitors.
Thank you very much.
Sure.
See, I knew he would know this stuff. So there are those assistance measures and things like that, which is always good to have for people. And again, though, it comes down to if you want to change your lifestyle, if you want to reduce body fat, whatever forms it comes in, you just got to start. You got to start eating a little better, working out a little more.
Absolutely.
And as a cardiologist, you couldn't stress that anymore, I don't think, because as you said to begin, I want to stress this. It's not just about the heart for you. It's so many other things about people's lifestyles and things that they're doing and the things that they have, like the belly fat and body fat, that are they counteract a good lifestyle and they counteract heart disease. It's
Absolutely.
It's why you're here as a cardiologist to tell people this may not be my lane over here, but I know enough about this stuff that it's causing this stuff. So
Right.
help us out.
And one thing that I have no doubt about is, especially when it comes to primary prevention of heart disease and heart-related events. In other words, preventing that first heart attack.
Yeah.
Okay. Diet and exercise are the best medicine. All right. There is no better medicine that I can prescribe than what I mentioned earlier, the American Heart Association's goals on diet and exercise. And if patients are able to stick to those goals, if they're able to cut down on their body fat, blood pressure is going to come down. Insulin resistance is going to improve. The A1C is going to improve.
Mm-hmm.
Blood sugars are going to improve. Cholesterol is going to come down. And for a lot of patients, that's all that's necessary for prevention of heart disease.
Yeah.
And so I can't harp on that enough. And then with secondary prevention, in other words, trying to prevent a second heart-related episode, a second heart attack, buildup of significant coronary artery disease.
Yeah.
It's equally important. I mean, we have data from cardiac rehab, just the importance of exercise and nutrition. Patients that complete phase 2, which is the part of cardiac rehab after a patient has a heart-related event, they're a patient that completes that compared to a patient that's had a heart attack and not completed cardiac rehab, their chances of having a heart attack going forward after completing phase 2 of cardiac rehab alone is substantially, some studies will say, half as likely to have a heart attack going forward compared to those that don't. And God forbid they do, their chances of that heart attack being fatal, it can be up to half as likely compared to those that haven't completed cardiac rehab. So that we know that for all adults, diet and exercise and reducing that body fat is very important.
Hate to show you guys that diet and exercise. I mean, I'm telling you. So let's say people are, they're getting their diet and exercise in order. What are some other general tips that you may have as a cardiologist? Somebody comes to see you. You're obviously going to patient by patient find out what kind of lifestyle habits people have. There are probably some other markers of things that people should not be doing.
Sure.
And things that you could do this, don't do this,
right,
on top of diet and exercise.
Well, obviously there's tobacco use. So that is, so many patients have been smoking, chewing since they were children. A lot of the time in West Virginia, in our area, probably across the country, I'm sure. But that tobacco use is a major risk factor for heart disease and many other things, of course. So that certainly counseling, equally important to diet and exercise, counseling should include tobacco cessation. That's really important. But another thing is a discussion about diet. So, it's easy for me to tell a patient, you should diet or you should eat healthy. A lot of patients say, well, I do. And so then we get deeper down into that and say, well, what do you eat? What kind of, what is a typical lunch, dinner, typical breakfast for you?
What is a healthy day of eating?
What is a healthy day of eating? And you find that there are a lot of misconceptions about what is healthy and what's not. Just as an example, a lot of patients I see, we try to tailor diet for high blood pressure, which should include lower sodium intake. There are so many different foods that we perceive to be healthy, cold cut sandwiches instead of a burger at lunchtime, instead of a fast food burger, even some cereals. We feel soup. We feel like we're eating healthy when we eat these things, but they're really high in sodium.
Yeah.
And when that might be okay, where that might be okay for some patients with high blood pressure, not good.
Not so much.
Not so much. And a lot of these eating habits start when we're children. We're not worried about blood pressure. Our parents aren't worried about blood pressure quite as much in their children. They take them to the pediatrician. Their blood pressure oftentimes is normal. Now, that's not always the case, but as parents, we often don't have reservations about giving our children macaroni and cheese or soup or, these things that are higher in salt. So what do the children do? They grow up and continue to eat the same thing. So it can be hard to break these habits. And also we perceive these things to be healthy. We've been eating it our whole lives. It may be macaroni and cheese, or it may be a cold cut sandwich, but it's not like a fast food burger. So, and while it may be healthier than one of those, still can cause problems when you eat them routinely.
So there needs to be a whole lot of education involved in, and again, that's an overwhelming thing. Just as the Prescription for Your Health program is trying to tackle overwhelming numbers and things like that, and that's why you do it. That's why we do it, and we have the resources available for people to get information about type of eating habits and things you think may be good versus things that aren't quite as good. There's things that you can do that are better for you. We circle this all back again to the topic was visceral fat, and I think being able to dispel some misconceptions about what visceral fat may be. It, in the end, just is you want to lower your body fat, period.
Yes.
Including visceral fat, including the fat around your heart, including fat in your liver. You want to reduce all that stuff.
Absolutely.
Visceral fat being a portion of it.
Absolutely.
Yeah.
And circling back around to something that you mentioned earlier, what do we do with that information on the InBody scan?
Yeah.
Again, there's nothing when we look at the percentage, the levels of visceral fat that tells me, oh, this number is better or worse than this number, but it is a great marker to look at your overall progress. That's how I would use it on the InBody scan.
Dr. David Francke dispelling myths, myth busting, if you will, and misconceptions. Come back earlier than 6 months later next time.
You got it. Sounds good.
Dr. David Francke, folks, thank you very much.